Welcome to the Hospital Medicine Unplugged podcast.
It's good to be here.
Today we are doing something a little different. Usually we are in the trenches of acute decompensation sepsis, respiratory failure, the things that kill you in hours.
Right, the immediate fires we have to put out.
But today we're taking a step back from the acute chaos of the wards to look at a syndrome that we see almost every single day. Yet arguably it's the one we misunderstand the most.
I would absolutely agree with that.
We are talking about upper motor neuron syndrome.
And before anyone tunes out thinking this is just a review of how to scratch the bottom of a foot to find the Babinski sign, let's be clear. This is about the mechanics of the nervous system rewriting itself.
Exactly. We all recognize the classic presentation. You walk into a room, you see the spasticity, the hyperreflexia, the extensor plantar response. It is bread and butter neurology.
It is. We see the signs, we document them. But the reality is the underlying pathophysiology, specifically how that spasticity is generated, is often really oversimplified in our minds.
And because we oversimplify the mechanism,
We drastically oversimplify the management.
I think that is the crux of the issue. We tend to treat stiffness as a monolith. We see a limb that is hard to move, and we throw a standard cocktail of medications at it.
Right, usually baclofen, maybe some gabapentin if we're confused.
Yeah.
And we just sort of hope for the best.
But if we actually dig into the sources we have for today, we see that understanding the mechanism changes everything. It changes how we differentiate neural spasticity from, say, soft tissue changes, and that dictates whether we should be reaching for a pill, a needle, or a therapist.
It's the difference between treating a neurological firing issue and a mechanical issue.
Right.
Two completely different problems requiring two different approaches.
Right. So here is our roadmap for this deep dive. We are going to start by looking under the hood at the complex pathophysiology of spasticity and why that old release phenomenon concept is actually wrong, or at least incomplete.
We'll also need to get into the nitty-gritty of assessment. We need to talk about why the modified Ashworth scale, which, we all use,
It's everywhere.
it might actually be failing us, and why the Tardieu scale is superior for that differentiation we just mentioned.
Then we're going to do a deep dive into specific etiologies. We will look at primary lateral sclerosis, or PLS, and hereditary spastic paraplegia, HSP. We have some really interesting data on diagnostic criteria and genetic markers there.
And we can't ignore imaging. We will discuss the motor band sign, which is a fascinating radiological marker, and then we will clarify that critical distinction between bulbar and pseudobulbar palsy.
Finally, we will wrap it up with a stepwise, evidence-based management algorithm that really ties it all together.
Sounds like a plan.
So let's unpack this. Let's start with the pathophysiology of spasticity. I think most of us were taught in medical school that spasticity is a release phenomenon.
Classic teaching, yes.
The idea being that the upper motor neuron is damaged, so the inhibition on the lower motor neuron is lost, and the spinal cord just goes wild. It's like cutting the brake cable on a car.
That is the classic teaching, and it's a very convenient metaphor. It's easy to grasp. However, the evidence suggests it is significantly more complex than that.
How so?
Well, if it were purely a release phenomenon, simply the immediate loss of supraspinal inhibition, what would you expect to see right after an acute injury?
You'd expect spasticity to appear immediately. You cut the brake cable, the car doesn't stop.
Exactly. But think about a stroke patient or a spinal cord injury patient. What happens immediately after the event?
In the acute phase, right after, we see flaccid paralysis, we see spinal shock, tone is low, reflexes are absent, the limb is limp.
Precisely. And the spasticity comes later. It can take weeks or even months to fully develop. So spasticity is a time-dependent process.
That delay, that's the key piece of evidence then.
It's the whole story right there. That delay tells us that there is something else going on. It suggests that there are plastic changes occurring in both the spinal cord and the brain over time. This isn't just a passive unplugging of inhibition.
It's an active process.
It is an active, maladaptive reorganization of the nervous system.
Maladaptive plasticity. So the nervous system is trying to adapt to the injury, but it is doing it in a way that is actually counterproductive.
It's trying to find a way to fire, and it creates new, messy, hyperexcitable pathways to do so. And one of the key mechanisms identified in the literature is this imbalance between the corticospinal and the reticulospinal contributions.
Okay, break that down. We usually just think corticospinal tract equals movement, full stop.
And that's true for voluntary fractionated movement. Moving one finger without moving the others, that's the corticospinal tract. But the reticulospinal tract is the older system, evolutionarily speaking.
Right, more primitive.
It handles gross motor tone, posture, anti-gravity muscles. Normally, these two tracks work in concert. The corticospinal tract keeps the reticulospinal tract in check. It refines its output.
It adds the nuance.
It does. But in spasticity, we see a specific shift. The spastic muscles show reduced corticospinal responses, which we would expect due to the damage, but they also show increased reticulospinal gain.
So the corticospinal tract, which handles that fine control, is dialed down. But the reticulospinal tract, which is just shouting, contract, maintain posture, is dialed way, way up.
Correct. The brainstem takes over, but without the finesse of the cortex. And this imbalance is happening alongside significant changes at the spinal level itself.
What's happening down there?
We see a reduction in spinal inhibitory mechanisms. Specifically, there is a loss of dysynaptic reciprocal inhibition.
Let's pause on that term because it sounds like neuroanatomy trivia, but it is actually the core mechanism of movement. Dysynaptic reciprocal inhibition. This is the wiring that ensures we don't fight ourselves right.
That is the one. In a healthy system, when you send a signal to contract your biceps, an inner neuron in the spine simultaneously sends an inhibitory signal to your triceps.
So the biceps contracts and the triceps must relax.
It must.
Yeah.
If it doesn't, you're just locking the joint. You can't move. In upper motor neuron syndrome, this inhibition is lost, or at least degraded, so you get co-contraction. The agonist fires, but the antagonist doesn't relax properly.
So the patient is trying to move, but their own muscles are fighting that very movement.
Exactly. And on top of that, you have increased intrinsic excitability of the alpha motor neurons themselves. They become trigger happy. Their resting membrane potential shifts closer to the firing threshold, so it takes less input to make them fire.
So you have loss of inhibition from above, loss of inhibition at the spinal segment, and a neuron that's just primed to fire.
It's a perfect storm for hyperexcitability.
And there is another factor here that I found really compelling in the reading, and it changes how I view the hospital bed, and that's the role of immobilization itself.
Ah, yes.
We often think of immobilization as a result of the paralysis. They can't move, so they are immobile. But the sources suggest the immobilization actually fuels the spasticity cycle.
It does. This relates to a phenomenon called postactivation depression. This is a physiological safety valve. Normally, after a nerve fires and activates a muscle, there is a mechanism that depresses its excitability for a short period.
Like a natural refractory pause.
Exactly. It's a natural refractory pause involving neurotransmitter depletion at the synapse. It prevents runaway firing. It prevents tetanus. It's a system to calm things down.
Okay, so it fires, then it rests.
Normally. But limb immobilization leads to a progressive reduction of this mechanism. The sources show that if a limb isn't moved, that natural calming down mechanism degrades. The synapse stops depressing itself after firing.
So because the limb isn't moving, the spinal cord essentially forgets how to turn itself off.
That is a great way to put it. The lack of movement essentially teaches the spinal cord to stay excited. It further fuels that hyperexcitability of the stretch reflex. This is why early mobilization is so critical.
Not just to prevent clots or sores.
No, but to actually modulate this neuroplasticity.
Yeah.
If we move the limb, we're maintaining that post-activation depression mechanism. We're reminding the synapse how to calm down.
That is a huge point. It shifts the view of physical therapy from just maintenance to essentially neuromodulation. We are treating the neurology by moving the biology.
That's precisely what it is.
No. Moving from the microscopic to the clinical, we use the term spasticity and hypertonia interchangeably all the time on rounds, but technically that is incorrect, isn't it?
It is incorrect, and accuracy here really matters for treatment. Spasticity has a very strict definition. It is a velocity-dependent increase in muscle tone caused by hyperexcitable stretch reflexes.
Velocity-dependent is the key phrase there.
It's everything. The faster you stretch the muscle, the more resistance you feel. It's that catch you feel when you move a limb quickly.
Whereas hypertonia is just the umbrella term for increased tone from any cause.
Right. And in a patient with UMN syndrome, the clinical hypertonia you feel with your hands is actually a mix of two different things. First, there's that reflex-mediated spasticity, the neural component we just discussed, the firing issues.
The velocity-dependent part.
Yes. But second, there's what's called intrinsic hypertonia. This is the biomechanical component. This comes from soft tissue changes, contractures, and rheologic changes in the muscle fiber itself.
So the muscle gets stiff, shorter, and fibrotic because it is just constantly contracted and not being moved through its full range.
Exactly. The tightened filaments change, the collagen builds up. So when you feel a stiff limb, you are feeling a mix of neural fire and mechanical stiffness.
And we need to know how much of each is present.
We have to,
Yeah.
because you cannot treat mechanical fibrosis with a neural suppressant like baclofen. Baclofen fixes firing, not fibrosis.
This brings us to the assessment scales. We all use the modified Ashworth scale, the MAS. It's a standard in almost every note I write. Tone 3 out of 4 on Ashworth.
It's ingrained in our practice.
But our sources are pretty critical of it. Why is the gold standard getting such a bad review?
The modified Ashworth scale is the most commonly used tool because it is easy, it's fast, but it has significant limitations. The main critique is that it quantifies overall hypertonia. It measures the resistance you feel.
But it can't tell you why you feel it.
Exactly. It poorly distinguishes between neural spasticity and that soft tissue stiffness. If a limb is stiff because of a severe contracture, the Ashworth scale will score it high, just as it would for severe spasticity.
So it is measuring the symptom resistance, but not the cause. It's like measuring a fever without knowing if it's viral or bacterial.
Precisely. That is why the Tardieu scale is often preferred in the rehabilitation literature, even if it takes a little more time to perform.
So how does the Tardieu work?
The Tardieu scale involves moving the limb at different velocities. You move it very slowly, that's called V1, and then you move it as fast as gravity allows, that's called V3.
And the difference between those two movements tells you the story.
Correct. You measure the angle of the joint where you first feel the catch or resistance. If you have resistance at high speed, V3, but not at slow speed, V1.
Then that's true, velocity-dependent spasticity.
Right, that is a neural problem.
Right.
The stretch reflex is firing because you moved it fast, but the muscle itself isn't mechanically stiff.
But if you have resistance at both slow and fast speeds, if it resists you even when you're moving it in slow motion,
That implies soft tissue contracture or intrinsic hypertonia. The muscle is physically short or stiff. The problem is in the tissue, not just the nerve firing.
that is a real aha moment for clinical practice, because if I do a Tardieu and find the resistance is there even when I move the limb in slow motion, pumping that patient full of baclofen or injecting botulinum toxin might not give us the result we want.
You might not do anything at all because we're dealing with a structural problem.
Which needs a structural solution.
Exactly. You might need casting, splinting, or even surgical release for that contracture. Whereas if the difference between the slow and fast movement is huge, the so-called spasticity angle, that patient is a prime candidate for botulinum toxin or oral anti-spasticity agents because the problem is the reflex arc.
Let's shift gears to specific disease states. We see UMN signs in stroke and multiple sclerosis all the time, but I want to focus on the pure motor neuron diseases, specifically primary lateral sclerosis, or PLS. This is a diagnosis that I think confuses a lot of people because it sits on that spectrum with ALS.
It does, and the distinction is absolutely critical because the prognosis is vastly different. Historically, PLS is defined as a pure UMN disease, so you get spasticity, hyperreflexia, weakness, but without the muscle wasting and fasciculations of lower motor neuron, or LMN, involvement that characterize ALS.
But the diagnostic criteria have evolved. The 2020 consensus criteria put a heavy emphasis on time. It feels almost arbitrary, but they draw a hard line at 4 years.
It feels arbitrary, but it's statistically derived. The consensus criteria break it down into probable PLS and definite PLS. Probable PLS is defined as 2 to 4 years of progressive UMN symptom duration.
Okay, 2 to 4 years.
And definite PLS requires greater than 4 years of symptom duration.
Why that 4-year mark? Is there something magical that happens at 48 months where the biology shifts?
It's all about the risk of conversion to amyotrophic lateral sclerosis, to ALS. See, ALS typically presents with a mix of UMN and LMN signs, but sometimes ALS starts only with UMN signs.
And it looks just like PLS at the beginning.
For a while, yes. The data shows that in patients diagnosed with probable PLS, meaning they have had symptoms for less than 4 years, about 33% of them eventually convert to ALS. They start developing those lower motor neuron signs later on.
That is a terrifying statistic for a patient. A 1 in 3 chance that what they think is PLS, which has a more or less normal life expectancy, is actually slow onset ALS, which is fatal.
It is a heavy burden of uncertainty. But once you pass that 4-year mark and enter the definite PLS category, the stability of the diagnosis improves significantly. Patients with definite PLS have significantly improved survival rates compared to those in the probable category, and certainly compared to those with ALS. So that 4-year boundary is clinically heavy. It's the safety zone, so to speak.
Now, regarding the purity of the UMN signs in TLS, the sources mention that EMG findings can be a bit nuanced. We usually think, if I see denervation on EMG, it's ALS, not PLS, black and white.
That is the general rule of thumb. But the sources caution us against being too rigid. Minor neurogenic changes, like fibrillation potentials or even sparse fasciculations, can occur on EMG in PLS.
So finding a few fasciculations doesn't automatically rule out PLS.
Not automatically. The extent and the significance of these LMN signs depend heavily on the disease duration. If you have a patient with a 10-year history of pure spasticity and you find very minor denervation in one muscle on one EMG,
You don't throw out the whole diagnosis.
no, it might not invalidate the PLS diagnosis. The system grades over time. However, if it's early in the disease course, say year 2, and you're seeing those findings, they warrant extreme caution and likely point toward an ALS transition.
Let's move to another etiology that we might see on the wards, perhaps in a younger demographic or with a different history: hereditary spastic paraplegia, or HSP.
HSP is a fascinating group of disorders. The core clinical presentation is bilateral lower limb spasticity, hyperreflexia, and extensor plantar responses. It's classic UMN leg symptoms.
And the mechanism here is distinct. It's a length-dependent degeneration.
Right. It affects the longest axons in the body first, the corticospinal tracts going to the legs. Imagine the metabolic demand of maintaining an axon that stretches from your brain all the way down to your lumbar spine. In HSP, the cellular machinery just can't keep up with that length.
That makes perfect sense, and that's why the upper extremities are often spared or involved much, much later. The axons are just shorter.
Exactly. The prevalence is roughly 2 to 5 per 100,000 worldwide, so it's not common, but it's not vanishingly rare either.
When we talk about HSP, we have to talk about genetics. It seems like there are 100 different SPG types. It's an alphabet soup.
There are many, but 2 mutations really dominate the landscape, and they are worth knowing. SPA-TAST, which is also known as SPG4, and SPG7 are the most frequently mutated genes. They represent about 9.2% and 4.8% of cases, respectively.
That is still a relatively small slice of the pie. Even if you add those up, we are under 15%.
It is, and that highlights the diagnostic gap. Even with comprehensive gene panels with next-generation sequencing, we only achieve a genetic diagnosis in about 30 to 49% of cases.
So more than half of these patients might have a clinical diagnosis of HSP, but no identified mutation. A negative genetic panel does not rule out HSP.
Correct. It absolutely does not.
Yeah.
And clinically, to help guide that genetic search and give a prognosis, we divide them into pure and complex forms.
Pure HSP being just the legs.
Pure or uncomplicated HSP is limited to the spastic paraparesis and perhaps some urinary urgency or mild sensory signs in the feet. Complex or complicated HSP involves additional neurological features, things like ataxia, cognitive decline, seizures, or extrapyramidal signs.
And if you see those plus signs, you are looking for a different set of genes than if it is just the spasticity.
A completely different panel in many cases.
Let's switch to imaging. We often order MRIs in these patients to rule out structural causes, tumors, stenosis, spondylosis. But can MRI positively diagnose these UMN diseases?
MRI is the gold standard for suspected UMN disease. And you're right, it's not just for ruling things out. There are specific positive findings we look for. The most well-known is corticospinal tract hyperintensity on T2 or Fell-Air sequences.
The bright stripe.
That's what it looks like. You see this bright signal tracking down the posterior limb of the internal capsule and into the cerebral peduncles. It's a sign of Wallerian degeneration in the tract.
But there is a more specific sign mentioned in the sources, the motor band sign. This one was new to me.
This is a really high-yield radiological sign. The motor band sign appears as hypointensity, as darkness of the precentral gyrus motor cortex on T2, or susceptibility-weighted imaging, or SUI.
And that darkness, that represents iron accumulation.
Exactly. It represents iron accumulation and neuroinflammation in the motor cortex. Microglia, which are the immune cells of the brain, accumulate iron when they're activated in a degenerative process.
Why is the sign so valuable? Is it just academic curiosity?
No, not at all. It has high diagnostic accuracy. The simultaneous presence of that CST flare hyperintensity, the bright stripe, and the motor band sign, the dark cortex, has a specificity of 81% and a positive predictive value of 90% for ALS.
90%. That's very high.
It is. And furthermore, the presence of the motor band sign predicts shorter survival. It correlates with the aggressiveness of the degeneration.
And the sources mention that motor cortex atrophy on MRI can be even more sensitive than our clinical exam.
That is a crucial point. Imaging can detect degeneration before UMN signs are clinically evident. The brain is remarkably plastic, right? It can compensate for loss of motor neurons for a while. It recruits neighbors to do the work.
So there's a subclinical phase.
Yes. And by the time we see spasticity or weakness, a significant amount of degeneration has already occurred. The MRI can potentially catch it in that preclinical window.
That has huge implications for future trials and early intervention. Now, before we get to management, we have to clear up a nomenclature battle that happens on rounds all the time. Bulbar versus pseudobulbar palsy.
This is a classic point of confusion. The distinction is purely anatomical. Pseudobulbar palsy results from bilateral UMN lesions, specifically lesions of the corticobulbar tracts.
Okay, UMN.
And bulbar palsy results from LMN lesions affecting the cranial nerve nuclei themselves, or the nerves as they exit the brainstem.
So pseudobulbar is UMN, bulbar is LMN, just like in the limbs.
Correct. And the clinical features follow that UM and LMN divide. In pseudobulbar palsy, you see UMN signs in the cranial nerves, spastic dysarthria, that strained, strangled voice quality where they sound like they're squeezing the words out.
A Donald Duck voice sometimes.
Yes, that can be part of it. You see a hyperactive jaw jerk and a brisk gag reflex.
Whereas in bulbar palsy, the LMN version, you would expect wasting of the tongue, fasciculations in the tongue, and a flaccid, immobile palate.
Exactly. And the hallmark of pseudobulbar palsy, the thing that really defines it clinically, is the pseudobulbar affect, or PBA.
This is often misunderstood as depression or mania, but it isn't.
No, it's a motor control problem.
Yeah.
It is uncontrollable emotional outbursts, laughing or crying, that are disproportionate to the context. The patient might feel mildly amused but start laughing uncontrollably, or feel slightly sad and burst into tears.
It is a disinhibition of the emotional motor pathways. The brake cable for laughing and crying is cut.
That's a perfect way to describe it. It's a motor release phenomenon of emotion. And clinically, PBA is strongly associated with the physical signs. The odds ratio of having dysphagia if you have PBA is 14.
14.
And the odds ratio of having an abnormal jaw jerk if you have PDA is nearly 20.
Wow. So if you see a patient with that kind of emotional ability and you check the jaw jerk and it's brisk, you are almost certainly dealing with bilateral corticobulbar tract degeneration.
You are, and you can then confirm it on that MRI we just talked about.
Okay, we have diagnosed the UMN syndrome, we understand the pathophysiology, we can separate the neural from the mechanical. Now what do we do about it? The management of spasticity.
Management needs to be a structured, stepwise algorithm. We shouldn't just be throwing medication at the patient. We need to match the tool to the physiology.
Step 1 is conservative.
Always. Physical therapy, stretching, bracing, positioning, these are foundational. As we discussed earlier, immobilization fuels spasticity via that loss of postactivation depression. So keeping the limb moving and stretched is physiologic treatment. It's restoring that synaptic depression.
Okay, so that's the base of the pyramid. Now, step 2 involves focal spasticity. If I have a patient whose main issue is a clenched fist or an equinovarus foot, just one or two limbs, I shouldn't necessarily sedate their whole body with oral meds.
Exactly. Why treat the whole brain for a problem in the left calf? For focal spasticity, the evidence heavily favors botulinum toxin. We have onabotulinum toxin A, incobotulinum toxin A, and abobotulinum toxin A.
And the evidence here is high certainty.
It is. Injections improve modified Ashworth scale scores for 6 to 12 weeks. The major advantage is that it has minimal systemic side effects. It's FDA approved for upper limb spasticity in adults and children 2 years and older.
And it works right at the source.
It targets the problem right at the neuromuscular junction. It cleaves the snare proteins needed for acetylcholine release without making the patient sleepy or confused.
But if the spasticity is generalized, if their legs are stiff, their trunk is stiff, then we have to move to step 3, oral medications.
Right. And here we have a few players, and we need to know how they work. Baclofen is the most common. It's a GABA agonist. Specifically, it works on GABA B receptors at the spinal level to inhibit the release of excitatory neurotransmitters.
And it's noted to be most effective for flexor spasms.
That's the clinical pearl, yes. Then we have tizanidine.
Tizanidine is an alpha-2 adrenergic agonist. It works centrally, similar to clinidine, but with less blood pressure effect. It reduces the release of excitatory amino acids from spinal interneurons.
What about benzodiazepines? We see them used from time to time.
Diazepam or clonazepam are GABA agonists as well. GABA usually, but their usage is really limited by sedation and tolerance. In a chronic management plan, they are rarely the best first choice because the cognitive cost is just so high, you're just sedating the patient to relax the muscle.
And then there is dantrolene. This one is unique because of its mechanism. It doesn't work on the nerves at all.
Yes, dantrolene acts peripherally. It inhibits calcium release in the muscle itself, specifically from the sarcoplasmic reticulum. It blocks the ryanodine receptor, so it has no CNS effect. That sounds ideal. No sedation.
In theory, yes. But in practice, you are essentially uncoupling excitation from contraction. Dosing is often limited by generalized weakness because you're weakening the muscle contraction mechanism itself.
So if they need that muscle tone to stand, dantrolene can take their legs out from under them.
Precisely. Plus, there's a risk of hepatotoxicity. So while it's unique, its efficacy in improving functional measures is often limited.
And finally, step 4, refractory spasticity. The patient who is maxed out on oral meds and still has severe disabling spasticity.
This is where we consider the intracerebral baclofen pump. The advantage here is simple pharmacology. Baclofen does not cross the blood-brain barrier very well when you take it orally.
And most of it never gets to where it needs to go.
Right. But if you deliver the drug directly to the spinal cord via a pump and catheter, you achieve greater efficacy at much, much lower doses, like 1/1100th of the oral dose. And this means far fewer systemic side effects like sedation.
But it involves hardware. And it comes with a black box warning.
A serious one. The risk of withdrawal. If the pump fails, or the catheter kinks, or the battery dies, acute baclofen withdrawal occurs. Because the body is used to high local doses in the spinal fluid, the rebound is severe.
What does that look like?
It is a clinical emergency. It can lead to rhabdomyolysis, multi-organ failure, and death. It looks like sepsis or malignant hyperthermia, so it requires a patient and a system capable of managing that hardware very carefully.
So we have traveled from the synapse to the MRI scanner to the rehab gym. We've seen that spasticity isn't just a brake failure. It's a complex rewiring of the nervous system involving tract imbalances and lost inhibition.
We have distinguished the neural firing from the tissue stiffness using the Tardieu scale, and we have differentiated the conditions like PLS and HSP that drive these symptoms.
And we have laid out a management plan that matches the treatment to the specific mechanism, whether that is local toxin for a focal problem or a pump for a generalized spinal one.
It really highlights that upper motor neuron syndrome is not a diagnosis to just write in the chart and move on. It is a dynamic process that we can characterize, measure, and treat if we pay attention to the details.
Absolutely. Before we sign off, I want to leave everyone with a final thought based on what we discussed regarding the MRI findings.
The motor band sign.
Right. We know now that imaging can detect degeneration, that iron accumulation and atrophy before clinical signs appear.
We can see the pathology before we see the phenotype.
Exactly. So if we can see the train coming before it hits the patient, are we moving toward a future where we treat UMN syndromes before the physical disability manifests? What would that treatment look like if we could catch those plasticity changes early enough to stop the maladaptive rewiring? It's something to think about.
It certainly is. The next frontier.
Thank you for listening.